Thank you and good morning again. Good morning. Thank you. We'll be talking about two data sets. One is 2023 European Society of Hypertension Guideline, which was announced in Milan in Italy in 2023. And the second, the 2024 ESC Guideline on Hypertension that was announced at London on the 1st of September 2024. Okay, but before we do that, understand that all that we are going to do is not discuss some big data. We would discuss that. But the idea would be how to fix a light bulb. How to fix a light bulb. Because the whole idea is the guidelines, if we look at them, the ESC guideline is 190 pages big. 190 pages, right? So they're huge big data knowledge. And we know how to navigate that knowledge and go up and the way and how to get to the goal. Finally, we have that bulb in hand. But unless we all understand where to put the bulb in use, all this knowledge becomes useless, right? So the point is, using the knowledge the right way is the most important thing. So what you do is, in the next 25 minutes, take the data out, discuss it for a moment, and for each data, we'll try to see how we can use this knowledge in our clinical practice tomorrow morning, Monday morning. So every data should be useful for you and me so that we can use it in tomorrow morning's practice. Otherwise, it is a waste. The first thing is this. The mercury manometer is out. We all know mercury is toxic. We have the aneroid machine, which we can auscultate and find out the blood pressure. And of course, we have the automated data, right? So many often people ask, what is the difference? Is automated accurate? Is there a difference and all that? So mercury is out, right? Now, if we look into the data and look into the concept of how we measure blood pressure, we know phase 1, phase 5, Korotkov sound and all that we were taught in our classes. And we know that it reflects that graph. That is the blood pressure. But if we are looking at an automatic BP apparatus, it has nothing to do with the sound. There is no microphone. It looks at the oscillation of each pulse and it looks at the peak of that oscillation peak. It's like a triangle, right? And from that peak, the automated system goes down by 50% on both sides, one side 50%, one side 70%. And that algorithm calculates 2 points, which are the blood pressure, right? So it assumes that there is a triangle there, the algorithm, and goes from the peak minus 50, minus 70 on both sides, systolic and diastolic pressure. Forget about all that. So what happens is the automated blood pressure, systolic blood pressure and diastolic blood pressure, this systolic is always slightly higher. And the diastolic is slightly lower. And very clearly the guideline says because it is oscillations, if you have an atrial fibrillation, this is invalid. So the data that has come in the 2023 and 2024 guideline, we translate into our clinical practice is that our automated blood pressure instrument gives a higher systolic pressure, slightly higher, a slightly lower diastolic pressure. You must have got calls in the middle of the night. Doctor, and BP 45, 55 kanikkunnundu. Endu 55? You 55 chance illa. Alla doctor 55 tanne aane. A lower BP. He is looking at the diastolic, right? See, diastolic BP, automated blood pressure instrument, tends to be on the lower side. And of course, it is unreliable in AF. So, automated BP instrument gives a slightly higher systolic pressure, slightly lower diastolic. But they're the gold standard now. Don't think that they're higher or lower. They are the gold standard, and all the diagnostic criteria, everything is based on them, right? We have also seen this blood pressure photograph in every book, and we just go through it, who bothers about all that. But did you realize that the back support that we talk about, patient should remain straight back, foot on the ground and all that, back support changes blood pressure by 4 millimeters. The feet Planted on the ground, we say that should be on the ground. We never bother about it. Patient beddil irikkum ingane kaalu thooki irikkum. That changes blood pressure by 8 millimeters. And the arm support, if not correctly placed at the heart level, changes the BP by 10 millimeters. So need to remind us that the Americans that talk things about, and yes, Europeans, they put it on the guideline. We don't care. We just say stand here and check the BP. There are differences, right? We need to be cautious. If we look into the 2023 ESH guideline, we all know that first thing you should give an ACE or an ARB, a RAS inhibitor plus a calcium antagonist or a diuretic. Go to the highest dose, fails, add up all three. And then of course try to give it one single pill, but we are not looking at that now. What came out as an unusual was this: beta blockers. Suddenly the European Society, which was saying that beta blockers are not at all in the first line, ACE, ARB, calcium antagonist, diuretic. From there they moved that beta blocker can be used even as a monotherapy and at any level of blood pressure. So suddenly beta blocker who was standing outside the hall has been invited to take the guest lecture, right? Now with that background, look at certain new concepts. One of them is speed. What speed? We are talking about heart rate and blood pressure. Heart rate and blood pressure. This is a large data that came in 2015 from the Stevo, Julius and Paolo Palladini's group from Italy. They took a data, very interesting, of 15,000 patients of a trial called Value Trial, which looked into valsartan, doesn't matter, and divided these patients into 5 distinct groups. Understand? So they divided the patients into heart rate less than 50, 50 to 60, 60, 70, 80, more than 80. And then they looked into the outcome. Okay, and when they looked into the outcome, look at that, the x-axis is the days, and the y-axis is the outcome. The best outcome was people who had a blood pressure which was controlled and a heart rate which was low. So heart rate nalla controlled and BP controlled, fine, they did well. But when they looked into people, look at that, whose blood pressure was good, controlled, but heart rate was faster, those patients didn't do well at all. In fact, when they took out that subset of the whole group, those who had a heart rate of more than 80, remember that number, heart rate more than 80, they found that their primary endpoint was 1.6 times higher, heart failure 2.2 times higher, MI, stroke, sudden cardiac death 1.5 times higher. So even when our patient's blood pressure is well controlled, very good BP follow-up controlled, their heart rate is high, we are looking at a bad outcome, right? And from that, remember that number 80, come to our own data, which we all did together, the India Heart Study, right? In the India Heart Study, we took 18,000 patients, very meticulously done data, a lot of people sitting here were in it, and then we found that the resting heart rate of the Indian population, Indian hypertensive, was 83.4 beats per minute, 83 beats per minute. So, Indian hypertensives, all our patients, hypertensives, have a rapid resting heart rate, much more than 80. And what did we say? Anything more than 80, we showed, has a bad outcome. Right? So that brings us, this is one of my favorite editorials where Takao Akishi looked into hypertension as 2 distinct divisions. He said hypertension on the left, those who have a heart rate less than 80, they are doing well, while those who have a heart rate more than 80 have a higher sympathetic activation and they would probably do better with a beta blocker. I mean, the reason is that's why all of us write so much of beta blocker for our hypertensives, right? Beta blocker is one of our favorite drugs. There's a reason for that. Indian hypertensives have a rapid heart rate Indian hypertensives have a heart rate of 83 per minute. So they clearly fit into that subset described by Takahashi. So from that rapid heart rate, for a moment, think about something else. India is a country, we all say that what? Diabetic capital of the world with 100 million diabetic, 140 million pre-diabetic waiting to become diabetic. And we know that in diabetes and metabolic syndrome, is very early activation of renin-angiotensin system. Very early activation of renin-angiotensin system, right? But then what we don't realize is there is even more to it. For example, this was one of this American College of Cardiology had asked us to do an expert commentary on ethnicity-specific BMI. Why? Well, there's so many Asians in US, right? So they were not sure whether their cutoff points are right or wrong. So we said no. Perhaps the 23 to 25 and more than 25 rather than 25 and 30 is right cutoff for us. But that is not we are focusing on. Focusing on this. India has more of visceral or central obesity, right? Which is different from the Westerner. We are not going to that. But look at the data. If you look at muscle sympathetic nerve activity, this is important. That means the sympathetic nervous activity of a muscle, and look at a person who is lean there versus somebody who is peripheral obese and somebody who is centrally obese. And that centrally obese person, because of the higher muscle sympathetic nerve activity, has a high resting heart rate. Now get the point. See, this is something that people fail to understand. I'm seeing a patient in the clinic. Opposite me, he's sitting there. He is obese, white, tends to sleep off, OSA, whatever he is, right? So we always know that he is metabolically abnormal, he needs statins, he needs ACE inhibitor, ARB, whatever. But did you ever think that his sympathetic system inside him is actually working overtime? Despite that fact, he is like this, obese. So the point is this, if we look into obesity-related hypertension, very important take-home point. Obesity-related hypertension, it's a very complex algorithm, forget about that. Start there in obesity, end there with hypertension. But if we pick up actionable points in the chart, one is what? RAS activation. One is what? Increased sympathetic nervous system activity. Sympathetic nervous system, did you think about it? And third, OSA. So if you have three actionable points for the obese patient sitting in front of me with hypertension and tending to sleep off, one, he needs an ACE or an ARB for treatment. Second, he needs a CPAP. And third, which we don't understand often or forget, is a beta blocker. So if we actually look into an obese hypertension Indian, we would probably need to target the RAS activity, the sympathetic nervous system activity, and give him, perhaps he has an OSA, a CPAP. See, this is something else. Let us for a moment pause. And we know that for Africans, RAS inhibitors don't work. And that's why even for heart failure, we give them hydrazine nitrate combination. So for African ethnicity, RAS inhibitors don't work. What about us? We are brown, right? We are not black, we are not white. There's hardly any data. So we formed a group of hypertension in the Asia Pacific region. This was a huge group. In fact, this was a group where there were people from Malaysia, Philippines, China, Myanmar, and this was an expert group that was called up. I was fortunate to be one of them. And then we are not going to that. We looked into every genetic polymorphism of the APAC region. We are not going to that. This is the final outcome. If we look into that, we found that we are very responsive, unlike the black, to RAS inhibition. As good as ACE and ARB, you see, comparable, and of course, beta blockers. So we have an equal sympathetic drive. We have an activated RAS, not just in metabolic or obese or anybody, but in the Asia Pacific region. So as our ethnicity, we have a high RAS drive. And that's why RAS inhibitors, that's the reason why probably things like telmisartan is so popular in India, right? Because we are driven. But take a moment and think about, have you ever thought about dementia? Right. When we wrote this article about challenges of hypertension and dementia in India in 2018, people laughed at us. There's no dementia in India at that point of time. But then over time, we saw that dementia is significantly increasing to the tune of now about 10%. Right. And what is interesting is this is data that has come out of UK Biobank. For those who are interested in medical learning, you know that UK Biobank gives us one of the largest database of data on very many things, and it's in free access data. And what they found was, if you look into the connection between UK Biobank data and resting heart rate and all-cause dementia, resting heart rate is clearly connected to dementia. So hypertension, resting heart rate, and dementia are connected. For a moment, let us look at something else. We all now are so familiar with ambulatory blood pressure. So for a moment, let us look into the blood pressure during sleep. Blood pressure during sleep. So if we know that, let us say, this is data from the Dublin outcome study, ABPM study. Look at the data. If we look into the x-axis, that is blood pressure, right? 90, 120, 130, 140, 160. And on the y-axis, we have 5-year cardiovascular death. Death, not a MI, stroke or anything, death. Okay. Now, if you say, my patient has a clinic, we are checking the clinic BP. The patient has a BP of 120. So his mortality is what? Somewhere 1, say 1.0. Now, he suddenly comes with a blood pressure of 170 or 180. Oh, severe hypertension. But where did his mortality move up to? From 1 to 1.2? Very little. But if we look at the nighttime BP, if his night blood pressure was 170, see the increase in mortality. So what we are trying to say is that increase from 120 to 170 reflects in a very small rise in event rate. But if that rise was in the night BP, the event rates are significantly elevated. That's why, as hypertension researchers, we always say, if you give me one data of blood pressure, give me the night BP data. Night BP data. And if we look into the Indian data, our published data of what we call as ambulatory BP data, India APBM study, huge study. This, when it came out, we found that this is one of the largest ABPM database in the world. 20,000 patient data. We found that 19.3%, 20% of our patients have what is called masked hypertension. Masked hypertension is hypertension where you have elevated blood pressure at night, but near normal blood pressure during daytime. Right. So this is like how it looks like. See, there's an ambulatory BP graph. That green is systole and the orange is diastole. That is day. Look at that day data. Slightly elevated BP, right? Slightly elevated. But that is night, the blood pressure is high. So daytime BP is near normal. Nighttime BP significantly high. This is masked hypertension, right? And we know that daytime blood pressure is driven by sympathetic. I'm standing here and speaking, my sympathetic nervous system is active. Those who are listening, or not those who are sleeping, those who are listening, your sympathetic nervous system is active. But when we go to bed at night, our sympathetic system goes to sleep, unless you are taking night duty in an ICU or in the cath lab. So you go to sleep, your sympathetic system comes down, so the night blood pressure is something that shows us a RAS and volume status. That's why we say night BP is so important. And now, of course, a person doesn't sleep well and all that, his sympathetic at night may be higher. And that happens, upblooded diabetes. See, this is one of our patients. I'll show you the data. Look at that data. Diabetic, hypertensive, 48 years, left ventricular hypertrophy, microalbuminuria. Look at that. The moment he came to the hospital, his blood pressure has gone up. What is it called? White coat effect. Not white coat hypertension. White coat hypertension means that will be the hypertension, rest of the time BP is normal. White coat effect. So that is white coat effect. Look at that. Night blood pressure, significantly elevated. Non-dipping pattern. Normally, at night, the blood pressure should have gone down. It has not gone down. Look at that early morning rise. Look at that. That is daytime sympathetic nervous system. That is nighttime angiotensin II driven night, right? And if you look at the heart rate, that straight line that you see below the diastolic blood pressure, heart rate, look at the night heart rate. That night heart rate should have come down when he sleeps. It didn't. Why? Because at night, this gentleman has a continuously driving sympathetic system. So these are people who have a continuously driving, activated RAS system and sympathetic system. So these are patients probably who need an ACE or an ARB and also a beta blocker. Now, one question that is always asked that, sir, all patient ABPM cheyan pettumo to know all this? No. There are millions of hypertensives in India. Can you do an ABPM for everyone? You cannot do, right? You don't need to do. So what do we do? So how do I cover up for nocturnal hypertension? How do I cover up for nocturnal hypertension? Simple. Even if you can't do an ABPM, all you do is choose a long-acting drug. So if you choose a long-acting drug, look at that, it'll cover up till your late night. And that is why we say today in treatment of hypertension, whenever you choose a drug, if you choose an ARB, tend to choose something that has a long half-life like telmisartan. You tend to choose a beta blocker, tend to choose bisoprolol. Choosing an ACE inhibitor, choose perindopril, long half-life, look at that. If you choose a diuretic, choose chlorthalidone or indapamide. If you're choosing a calcium antagonist, choose something like amlodipine or azathioprine, which has a long half-life. So if you choose a drug with a long half-life, whether you are doing an ABPM or not, the 20% of masked hypertension, which you might have missed, I might have missed, is covered up. So it doesn't matter whether I did an ambulatory blood pressure or not. Right. We will finish off with one last concept, very important concept. I think this needs to be understood. This is very new. This just come out in that 2024 guideline, and that is this. If we look into blood pressure, the ESC guideline clearly says any number, now you need not bother about number, 140, 90 and above is hypertension. Very clear. And anything 120 and 70 below is normal. But there's a gap in between, right? And that is what the European Society has labeled as elevated BP, like elevated sugar, elevated cholesterol, elevated BP. Right? So the concept is simple. If you have hypertension, it's very risky. It's like a skyscraper. You fall from the skyscraper, you hurt yourself, you die, right? In contrast, elevated BP, most people think, slight elevation, steps on the way. But the point is, you can still fall from a step and hurt yourself badly. So the 2024 new guideline, who is at high risk in elevated BP group? That is the question. So tomorrow you see a patient who has a blood pressure between 120 and 140 systolic, 70 and 90 diastolic. Oh, and I've heard that lecture, I've read that guideline, I know it's elevated BP. Do I need to treat or not? Now, forget about all these numbers, we'll skip quickly that. That is a number, so you have home blood pressure, ambulatory BP, and the numbers you can always... See, 2015, the whole thing, why it came, the conceptual understanding, 2015 we had a trial called Sprint trial, which showed that 9,000 patients between blood pressure of more than 140 systolic and less than 120 systolic, 120 and less systolic had a 25% lower primary event rate, better. There was a 27% lower death rate. So Sprint said, yes, you should reduce the blood pressure by drugs. Okay, then we had the STEP trial, which took elders. Similar, 26% reduction. Then there was a trial called BP Road, which is just presented about a month back in the ACC, the AHA at Chicago, T2DM, blood pressure less than 140 or less than 120, very clearly there was a 21% reduction. So every data showed if you vigorously treat blood pressure in that elevated BP range, you benefit. And then depending on that, they brought out this complex algorithm. Takes 1 minute to understand, but worthwhile, focus, understand it. So how do we go? So we have a patient whose blood pressure is between 120 and 140. Diastole 70 to 90. So we said it is elevated BP. How do we treat? So if the patient has a cardiovascular disease, diabetes, CKD or hypertension mediated organ damage. Bhayankara prashnama. CVD and CKD and cardiovascular disease, we will wait for 3 months of lifestyle. If it fails, we give medicine. So patient is very high risk. Cardiovascular disease, CKD, what we do is 3 months of lifestyle followed by medication. Very clear. If the patient has none of those, CKD undo illa, diabetic no, CKD no, nothing is there. What do we do? Then we risk stratify using a risk score called SCORE. We'll look into SCORE a little later. But then if the SCORE risk is low, we just follow yearly follow-up. If the risk score is intermediate, the score is high, automatically it goes just like the previous algorithm. If the risk score is intermediate, we look into very many things. They have given a huge list. Coronary calcium, this, that, forget about that. If you read the data, you see there is ethnicity. Where they are saying South Asians. So forget about everything. So South Asians, see now look into the risk chart that they give for the highest risk of the Europeans. Europeans, they have divided into low risk, medium risk, high risk. The high risk category, look at that. If you take somebody who has a systolic BP between 130, 120 and 140, elevated BP, borderline, he is between 40 and 45 years of age. He has a normal cholesterol. Look at that risk, 5%. So what we are trying to say is that a large majority of our population eventually would need medication for those between 120 and 140, right? So if you look into this is the thing that we need to take home. On one side we have non-elevated BP. On the other side we have hypertension. Non-elevated, only exercise. Elevated BP, hypertension, lifestyle and drugs. Drugs and lifestyle. But if you have elevated BP, you see a lot of these patients beyond 3 months of lifestyle would need medication, and they would be people with multiple risk factors, people with nocturnal hypertension, people with faster heart rate, people with visceral obesity, and perhaps just being Indian. Right. This is one of our patients. Look at that, elevated blood pressure. BP is actually a lower side, but then you see the daytime, nighttime, he has significant night BP, right? And of course, look at his heart rate, elevated. So these are patients who, despite being in that elevated BP group, needs drug treatment, right? So we will quickly skip all that and go to something that is very important, that is new thing that is coming up is low dose combination. Before we finish, you need to know about low dose combination. Low dose combination is something that is absolutely new. They've tried this out and look at that. So a patient of hypertension comes in. Okay, I'm writing amlodipine 5. Or you are writing telmisartan 40. You think, yeah, if it is not controlled, I will increase. But the new concept is right at the beginning, they are giving drugs at an incredibly low dose where if I had written or you had written, we would be thrown out of the class. 10 milligram telmisartan, 10. 1.25 of amlodipine and 0.625 milligram of indapamide. Incredibly low dose, and of course they have shown the benefits and all that. So what is coming in is that rather than when the patient comes in, giving a 40 milligrams of telmisartan or 5 of amlodipine, think that maybe in the long run, I would be doing much better by giving a 10 of telmisartan and 1.25 of amlodipine with a better BP control and less side effect. And the long-term benefit, that is a topic by itself, we are not going to that. But finally, this is something we will end with the trajectories of blood pressure in women. A lot of women come post-menopausal, right? Now, if you look at postmenopausal women there, menopause, there are 3 distinct types. If you're not aware, Please listen carefully because this is the last slide. Important. One category, you would find that the blood pressure is high, but after that straight line of menopause, it tends to slightly decline. Second category, it was medium, but progressively rising. Doesn't matter whether she has gone through menopause or not. But there is a type where the blood pressure was normal till menopause, has gone up significantly. And that carries the highest cardiovascular risk. We're not wasting time on that. This carries the highest cardiovascular risk. So somebody who comes and says, Doctor, BP right after menopause, my blood pressure has gone up. That lady carries the highest cardiovascular risk. So where are the light bulbs at the end of all this 31 minutes? One, automated blood pressures that we use daily record a higher systolic, lower diastolic, and is unreliable in AF. I mean, that is the gold standard, right? Second, heart rate control is vital in India. Heart rate. Apart from blood pressure, heart rate control is extremely, extremely important for the sake of prognosis. The obese patient who sleeps in front of me carries not just an heightened RAS, but an activated sympathetic nervous system and might do good with a beta blocker. Nocturnal blood pressure and elevated BPs are things where we need to put our mind and make our way correctly. Low dose combination therapy is coming in. It is coming in a big, big way, right? And finally, postmenopausal blood pressure rise is a bad news. Thank you for your time and attention, and sorry for exceeding by 1 minute.
Thank you, Tiny, for that very, I would say, inspirational talk or enlightening talk, posing a lot of questions which we all have been talking all these years. Hypertension, I would say, second to death is the biggest leveler, because whether you look at Somalia or Sweden, New Guinea or New Zealand, hypertension is the most important cause of morbidity and mortality. But of course, there are a lot of questions to be answered. As we answer one question more, as we conquer one peak, more and more peaks come in front of us. So I think it is a never-ending story, and Tiny is one person who can probably poke your thought process into what next. Beyond the lack of time, I think we will not have any questions from the audience. Just a word from Dr. Jayaraj and Dr. Udevan.
It was a brilliant talk, Tiny. As a nephrologist, I would like to say that we all go by eGFR nowadays. And eGFR is dependent on serum creatinine, and which is a very poor index of renal function. So when classifying the CKD, and because I'm happy that CKD is now recognized as an important risk factor as far as cardiovascular disease is concerned. Here, proteinuria is the most important. And when you treat a case of hypertension with drugs, you look after the proteinuria, and then if the proteinuria is getting controlled, now we do have, say, standard of care, goal-directed therapy, so many things are coming up. But everything has to depend upon serum, the proteinuria, if the patient's renal function has to improve or stabilize. Thank you.
100%. I think we should all go home remembering that when we talk about CKD, or today we are talking about the kidney events, it is not just the eGFR, but eGFR plus proteinuria. We are looking at eGFR percentage of dropping, or serum creatinine doubling, or microalbuminuria, proteinuria increasing, and of course renal endpoints like renal death, transplant, or renal replacement therapy. Yes. So we should not forget microalbuminuria, proteinuria in addition to the eGFR which we refer to. Absolutely.
In some cases of renal failure, we find it very difficult to control the BP. Is there any newer drugs?
Yeah, I think one of the most difficult to control would be resistant hypertension causes CKD. And CKD, we have to be extremely careful because, for example, many of these new drugs, like today, you would have seen that ARNI has come in a big way as an antihypertensive. Today, resistant hypertension, we use ARNI, but ARNI has a problem in CKD, right? your GFR might go up, your potassium might go up, and all that. We are using SGLT inhibitors. We use, by third line is over, we use what? We use MRAs. But MRAs has a problem of hypokalemia in the background of CKD. So CKD has so much of problems. Alpha blocker CS, moxonidine is one drug that has come in a big way in CKD, not because of anything else, but because, moxonidine has an ability like a beta blocker to lower heart rate. So you have to be careful. Your basic should be an RAS inhibitor carefully so that the GFR doesn't go up. Second, you have CCBs. Diuretics, your choice should be dependent on the CKD background, and alpha blockers and vasodilators and all the new drugs would come in. It's a topic by itself. Thank you.
Thank you, Tiny. A very insightful talk. And we can all see your excitement when we are talking about hypertension. And this excitement, I hope you could give it to the audience as well. I wish we had more time. Sorry, but I think there will be another opportunity. Thank you very much.